Thank you for joining us this evening for this Stryker ENT webinar covering tools for successful sinus patient outcomes. We're looking forward to a productive discussion led by Dr. Nipun Chhabra and Dr. Nora Perkins. Before we begin, a few tips for the audience. Attendees may submit questions anytime using the Q&A icon at the bottom of the Zoom screen. The chat function has been disabled, so please submit your questions via Q&A, and we'll take time at the end of the presentation to respond. Additionally, this presentation will be recorded. Now I'll hand it off to you, Dr. Chhabra.
Well, thank you, Allison, and thank you to the Stryker team for hosting this webinar tonight. My name is Nipun Chhabra. I'm a fellowship-trained rhinologist in academic practice in Cleveland, Ohio. Certainly appreciate everyone joining us tonight, and we're excited to be discussing tools for successful sinus patient outcomes with you. I'm privileged to be joined by Dr. Nora Perkins, my colleague in Albany. I'll turn it over to her.
Thanks, Dr. Chhabra. I'm Nora Perkins. I am a general ENT in private practice in Albany, and super excited to talk to you all tonight about some of our hybrid cases and how we use balloons and traditional surgical techniques for our patients. So we can probably move on to the next slide. So I'm sure all of us, whether you are a rhinologist or you're a general otolaryngologist, are seeing a lot of patients with chronic sinusitis. Super prevalent, right? 31 million adults in the US suffering from sinus disease, 18 plus million office visits. I don't know about you guys, but our primary care physicians are not necessarily seeing sick patients. So I feel like this office visit specific to the ENT might be increasing because these patients aren't even necessarily seeing their primary cares for their episodes of sinusitis or sinus infections. But because of that prevalence and because, it's a significant quality of life impact, patients aren't able to work, they're not feeling well, they're not able to participate with their family. It's a huge cost. So over $3.4 billion annually. So pretty significant, both with regards to the number of patients and also the disease impact. So we can move on to the next slide.
Yeah, so I think this is a good kind of summary slide that really shows the three sort of buckets that are available to us for how we treat our sinus patients, and really kind of when we are deciding what type of surgical intervention to use. So, I think all of us are familiar with many of the techniques on the slide. For example, traditional FESS, we often use for patients that have moderate or severe chronic sinusitis, or patients that might have polyps, fungal balls, AFS, things like that. And we're, in those cases, we'll be using our traditional instrumentation. We'll be doing sinusotomies, antrostomies, thoracotomectomies. In my practice, the balloon has really kind of evolved as a great tool for, in my experience, patients that especially have more mild disease or mild CRS, or even some of the recurrent acute patients. And I think that subtype of recurrent acute patients especially can be a little bit more challenging, right? Because, those patients, we may get a scan back that says normal CT, but, we've seen those patients with multiple rounds of sinus infections, or we document and we look at the CT, and then we're documenting concha bullosa, we're documenting Hauer cells, we're documenting narrowed OMCs. And I think historically, at least in my practice, these were patients that I was taking to the operating room and I was doing limited sinus surgery on them, maybe just addressing the maxillary sinuses or doing the anterior ethmoids or doing a little bit of frontal work. But I've really found the balloon to be a great tool for providing relief and quicker recovery for those patients, whether in the OR or in the office setting. And the last kind of bucket is hybrid FESS, which I think both in the literature and also just in clinical practice, we've seen this term kind of gain a lot more attention in the last decade or so. And that, encompasses a set of techniques where we're using the balloon as a tool in conjunction with our traditional FESS techniques. So maybe you're using the balloon for dilating the frontal outflow or helping you to find the tract or the pathway, but then you're going on to perform a traditional frontal sinusotomy with your traditional instrumentation. Or maybe you're using the balloon to dilate the sphenoids and the frontals, but then you might still be doing some level of ethmoid work or maxillary work with your traditional instrumentation. So it can kind of encompass all those different tools and techniques that we use, but the takeaway is that we're using the balloon in conjunction with our FESS techniques. Next slide.
So I'm sure you've seen all of this literature at some point. This has been, many years, many different studies that have studied the balloon by itself, used for balloon-only procedures, but also used in conjunction with traditional procedures like Dr. Chhabra was mentioning, and hybrid procedures. And these studies have all shown the safety, the efficacy, and the durability of the balloon. So it's really well studied, a lot of literature to support it. Next slide.
So, balloons can really be effective tools. And I think you kind of we touched on this a little bit, but for me, one of the evolutions in my practice of how I sort of became comfortable with using the balloon, and especially the XprESS device in my opinion, is that it felt like a natural extension of what I was already doing in the operating room. Right. So I'm sure we're all familiar with certain frontal instrumentation, whether you have a curve navigation probe that you like, or a frontal curette, or a seeker of some type. And I felt like the strength of the balloon really, for me, was helping to translate that from the operative setting into how I was going to use this in the office, or even in a hybrid case, especially for frontal surgery. And I think that's one of the strengths of how that balloon is designed, with the tactile feedback and the seeker really kind of feeling much like the instrumentation I was already used to. So for me, I think it was sort of an evolution of bringing that from the operating room into the office, and using instrumentation that I already felt pretty comfortable with.
I had a really similar experience, actually. So I trained using balloons, but I was using a wire-based system. And so that was what I was comfortable with, because it was what I had been trained with. So making the transition initially, I was honestly a little bit nervous about it, but I started using it in patients in the operating room and realized that it was really incredibly similar to the frontal sinus seekers that I was using, and as you mentioned, to other kind of traditional devices. So in fact, what I found was that I liked it more because I got the tactile feedback that I liked from those devices, and I felt like I was a little bit more able to tell where I was in the sinus because I was getting that feedback. So now I still do cases in the operating room, but I also find that it's incredibly helpful for moving cases into the office. The XprESS device is incredibly small. So in tight anatomy, using local anesthetics, we can successfully dilate the frontals, the maxillaries, the sphenoids, in combination with, if we need to do a more traditional antrostomy or ethmoid work, we can do all of those things in the office. But I think the real benefit, particularly in the patients that Dr. Chhabra was mentioning, who are the recurrent acute patients, those patients, if you're using a balloon, we're preserving the mucosa. I think in my hands, I think I create less trauma when I'm using the balloon, particularly when I'm using image guidance, because I'm not really searching around or just poking around, if you will. I'm kind of directing my device right where I want it to go, and trying to create the least trauma possible while opening the pathways. And it's a really easy way with multiple ways to confirm that you're in the sinus. So you have the tactile feedback, you can feel, for example, in the frontal, you can feel the lateral excursion, you can move it, almost 180 degrees side to side. If you're using image guidance, that's another way for confirmation. If you're not, then the light, the transillumination, is a really nice way to also confirm placement. So we can go ahead and move on to the next slide. Okay, so now we're going to start with the fun stuff. We have 4 different cases that we're going to talk about, and they each have a poll with them. So we'll put up a slide, we'll talk about the case a little bit, and then we will put up, for the first 3 cases, this poll asking if you would do a FESS, if you would do a standalone balloon procedure, or if you would do a hybrid FESS. And then you guys can submit your responses, and we'll see your responses, and then we'll talk about what we would do. So we can move on to the next slide. Okay. So this lady is 65 years old, much like Dr. Chhabra had mentioned before. She is the person who presents repeatedly with recurrent acute sinusitis. She, may have gotten antibiotics from multiple urgent cares in the outside world, but she's also been seen in your office. You've seen purulence, you've treated her. She's using your budesonide irrigations. She's managing her allergy. She's doing all the stuff, but she's still getting infected in repeated courses of antibiotics, which understandably she's not super happy about, right? We all know that repeated courses of antibiotics can create all sorts of other quality of life issues for patients, and just generally being sick and requiring numerous courses of antibiotics is not a great quality of life. So on the scan here, I think we can see a few different things. I would say her anatomy is incredibly tight. Like if we look in her right osteomeatal unit, it's not exactly obstructed, but there is very minimal space because of that concha bullosa. On the left side, it is completely obstructed. Little hard to tell from the coronals, but I think on the left, we can see a Haller cell. On the right, maybe we can see the edge of a Haller cell. You know, certainly her inferior turbinate's really hypertrophic. So she has incredibly narrow anatomy. And even though this sinus CAT scan, you know, isn't completely opacified and doesn't have 7 millimeters of mucosal thickening throughout, you can see how she becomes obstructed and develops the sinus infections. So let's put the poll up. And essentially, everyone kind of comment about how they would treat this patient. Maybe we should have had a fourth choice of like, I'm not going to do surgery on her. I'm just going to keep giving her, you know, 6 antibiotics a year. That could be an option, I suppose. But would you do a traditional sinus surgery? Would you do a balloon only procedure or a hybrid FES? So I don't know if that was enough time for us to get results or not. But these patients are challenging because I agree with you, Dr. Chhabra. Like I would, you know, if I didn't have a balloon, I would take this person to the operating room and do some type of antrostomy, right? Okay. So people are saying that they would do hybrid procedure. The majority of people are saying hybrid procedures. Some people doing the standalone balloon and some people doing the FES. So I'm going to pass it over to you, Dr. Chhabra, just to say, how would you treat this patient?
Yeah, so this is a great case, and you know, in this kind of a circumstance, I think that either way, I mean, a hybrid or a balloon, I think would be appropriate. I can see the tendency to want to do a hybrid because, you know, you see some of that osteomeatal complex obstruction, like you mentioned, a little bit of maybe mild ethmoid disease. You want to take down some of that ethmoid, maybe just the anterior ethmoid space and just do an anterior ethmoidectomy, maybe just taking down the bulla, and then you want to excise that concha. In this case, I think a balloon alone would be totally appropriate too. I do think that taking down that concha is helpful, and maybe just taking down a single cell. But, you know, is it necessary to definitely do a full antrostomy, sphenoidotomy, frontal sinusotomy? I think this patient would get better with a balloon only, and maybe just kind of an intraoperative call for saying, hey, yeah, I might just take down that anterior ethmoid cell on the left side just to create a little bit more room. How about yourself, Dr. Perkins?
Really similar. So I would probably, you know, again, I would tend to err on the side of she's never had surgery before. You know, there's a pretty low risk in us doing a balloon only procedure because I would do it in the office, so she wouldn't have to have anesthesia. So I would probably offer that. I think I would have to address the concha. There is a really lovely instrument that is part of Stryker's mini office instrument set. It's a middle turbinate forceps, and it's a really atraumatic way to just crush concha. So usually I'll tell patients, you know, I'm probably going to either resect that or I'm going to resect the lateral portion of it. But sometimes I crush it and it's completely, you know, obliterated and fractured, and it's amazing. So I think it has to be addressed, but I would probably think about doing a balloon only case as a first time. Now, to your point, if you get in there and all of a sudden that left side, the uncinet's super floppy and, you know, it's just doesn't seem like it's really going to be successful, you could certainly do an antrostomy on the left and a balloon on the right, right? You could do it. You don't have to do the same thing on each side. You could do sort of a hybrid from side to side. So that's how I would treat it.
Right.
Right,
And I would also just,
go ahead.
Absolutely. No, I would just comment too that they also do the sickle knife, which is great in the instrumentation as well. And you know, I've excised these lateral lamella of the conchas in the office, and sure, it's, you know, the patient's awake, they're feeling things. So are you going to get the beautiful resection that you might get in the operating room? I mean, sometimes it's a tendency of how much to do and how much and knowing when to stop.
Right.
But certainly excising it is also something that they can tolerate quite well.
Yeah, it's pretty remarkable. Again, I find you know, this isn't the talk for that, but I do the same exact anesthesia protocol pretty much for every case. And it leads to a pretty consistent patient experience and ability for me to do the cases. So it's, you know, a really nice way to at least do that initial procedure for her. So we can move on to the next case. Dr. Chhabra, I think you're going to talk about this one.
Sure. So yeah, this is a 42-year-old gentleman who presents to you. has had prior polyp removal surgery, and it looks like they'd had maybe some polyps removed, maybe not full antrostomies or ethmoidectomies that were done. And you've done a fair number of medical management. You've done your rounds of budesonide rinses. You've probably put in some oral steroids and given the patient a couple rounds of antibiotics. And now this patient is presenting here for kind of what the next step is. And in this sort of circumstance, we see that the CAT scan shows there's some osteotic bone. There's some thicker cells along the ethmoid. It looks like the polyps are obstructing most of the nasal cavity. And you've got pretty much almost pansinusitis. Maybe on the sagittal, you can see that the sphenoid doesn't look too bad, but that sphenoethmoid recess, posterior ethmoid cavity is pretty much obliterated. So in this kind of circumstance, what are the choices? What are we going to do? A FESS, a hybrid, or a balloon only? I can bring up the poll question.
I think this is an interesting case because, again, I mean, they've had prior surgery, but it certainly looks like there's room for more surgery, and not just the polyp, right? It looks like more, ethmoid residual cells and whatnot, and a lot of polyp disease. I know when we were sort of, going over these cases, also roles for possibly biologics or other things to manage this medically to make our surgeries look even better. But assuming the patient said absolutely not to that, they can't breathe through their nose, they want to feel better, right?
Right, and that's a great point because the patient's already had surgery, right? Now that we know their polyps are recurrent, so is that going to be necessarily the better option in this case? It's so it looks like here we have our answers back, and pretty close split, but it's between a hybrid FESS and a traditional FESS. So Dr. Perkins, I'm curious to hear your thoughts on this case.
Okay, so I wondered, actually, I was kind of surprised to see that because I was going to say a hybrid FESS, which I thought was going to be like, blasphemy here. But I think, definitely this person would benefit from, revising the ethmoids, removing the remainder of the ethmoids, at least maybe a revision of the maxillary, not that there seems to be a lot, but getting the polyp tissue out. But I think I would probably use the balloon at least to find the natural drainage pathway for the frontal. And then I would probably do a more traditional frontal sinusotomy, and probably the same thing for the sphenoid. I might balloon it. And if it's, after taking out the polyps that were in the sphenoethmoid recess, the balloon sphenoidotomy looks great, I might leave it alone. If it kind of looks a little dicey, like there's, just a ton of polyp tissue or inflammatory tissue, then I would do, a more traditional sphenoidotomy. But I think a hybrid approach would probably be my plan going into the case. What about you?
Yeah, I don't think it's blasphemy at all. I mean, even the audience poll was almost halfway split, right? I think in my personal preference in this case, I probably would do a traditional FESS. I think that there was, or there appears to be a little bit of osteotic bone. I'm, a little bit maybe concerned about some of that disease around the frontal. Am I going to be able to adequately clear it? But certainly, I think that using the balloon to help increase the speed of finding that outflow, especially because it is narrowed and there is, a fair amount of soft tissue thickening, is definitely going to increase the speed to get to that frontal too, and will help you. This could also be a very bloody dissection, right? Recurrent polyps, the osteotic bone, probably fibrous polyps. So sometimes just the visualization can be difficult for this kind of surgery.
That's a great point too, because I'm sure this would be not only incredibly inflammatory, but just everything's going to be super distorted, right? Like nothing is going to look like it should. So I think that, having something to help guide you in the right way is always going to be helpful. But yeah, so anyway, that was an exciting poll response because I did not know if that's what we were going to get.
Yeah.
All right, let's move on to the next poll. Okay. So this 35-year-old lady. So she has also had prior sinus surgery. It looks like a little bit more involved sinus surgery than the last patient. And certainly she does not seem to have any recurrent polyps, but she's got this pain and pressure in her forehead. And so, I think we can see why she has pain and pressure in her forehead. That right frontal sinus is completely opacified. There are some frothy kind of secretions in the left side as well. On the sagittal, it looks like, I don't know if that's a little residual like agar there, but there's definitely some residual cells, probably some scarring, I would, guess, because it doesn't look like it's just completely obstructed. So let's put up the poll and see what people would do. Okay.
Yeah, this is
Any
this is
other
a
thoughts
great.
about the scan, Dr. Chhabra?
No, I was totally just going to comment. I totally agree with you. I think that there does appear to be some residual auger on that right side, which is possibly why that right frontal outflow might have been impeded, however many years later. But agree, the rest of the sinus surgery looks like it was done pretty thoroughly and quite complete without residual partitions or significant blockage. And certainly this patient looks like they only had just kind of unilateral symptoms just around that frontal. And that can always be challenging because if the frontal isn't always totally opacified, sometimes you want to elicit that history without prompting the patient. Where exactly do you feel the pressure and how much of that frontal is really the problem? But in this case, I think it's pretty clear.
Yeah. Okay, so group has spoken. So the majority of people are thinking that they would do a hybrid procedure, about a third standalone balloon and a little less than 20% traditional FES. So Dr. Chhabra, what do you think? What would you do?
Yeah, I think in this case, the balloon is a great tool to find that outflow and really just kind of pop into that space. And but there is that auger cell that does seem to be a little bit blocking and impeding that frontal. So I would like to take that auger down, especially because the rest of the sinuses were so thoroughly cleaned that I don't really see any other disease anywhere else except for that right frontal. But I wouldn't want it to necessarily potentially scar back down again. So I would just probably take down that auger a little bit, but really primarily be using the balloon to open up that frontal and get whatever mucus or secretions are out.
Yeah. So I think that I would do, I think I would be similar. I would probably do this patient in the office. So I have image guidance in the office, and I don't know about you, but I would 100% want image guidance for this case. Would you do this without image guidance?
I think image guidance is, I totally agree. Yeah.
Yeah. So image guidance in the office, I would plan to use a balloon. I would track the balloon. And then depending on what the dilation looked like after the dilation, the other thing is after dilating, I'd probably use like the cyclone to rinse out the sinus, get all the mucus out of it. And if it was really nice and wide open and that auger really looked like it had kind of been adequately addressed, then I might put like a steroid eluting stent up there or something like that and kind of leave it alone. If it looked like there was just, residual bony tissue that needed to come out, then all of a sudden it becomes a hybrid procedure. But that's the funny thing. Like, I don't think you have to really choose one or the other. It's kind of, as you're doing the case, just like with anything, your plan, you might go in with an initial plan and then your plan changes a little bit, but essentially you have all the tools to be able to do, whatever you need to do.
Right. And I totally agree. I think that the other thing too about in this case, the one thing that I think the balloon would be so nice is that the anatomy is pretty favorable too.
Yes.
So even though there is that auger cell, looking at that sagittal, it's a pretty clear shot up there with your navigation. You're making sure you're in the right spot. You're not accidentally dilating the auger. And if you got that open with just the balloon, I mean, that auger is really at that point not even relevant anymore.
Right. And it's funny you say that, but you're right. I think if it's looking at it, I'm like, oh yeah, it looks like it would be, I don't want to say easy. It looks like it would be very doable to do it with the balloon. But again, the image guidance I think would be critical. So, all right, let's move on to the next slide.
Yeah, so this is, navigation. We're kind of changing gears here a little bit just to talk about navigation. When is it needed? How often are we using it? I think that navigation has really changed the way we do sinus surgery, whether in the office and in the operating room, in both places. And I think that what has happened with navigation is it's given us more confidence, right? So now we have the ability to pre-plan our surgeries. We can use planning software. We can use things like building blocks and tools to kind of really help trace some of our pathways that otherwise sometimes are underappreciated. Some of the things that we spend a lot of time sometimes skipping over, say, for example, the maxillary, we now have tools that could help us to make sure, are we really in the right place, or are we dilating, an accessory or iatrogenic ostium potentially. And I think what navigation we've really seen is sort of an evolution over time. You could navigate things like curettes or forceps or Blakesleys or your favorite type of seeker. I don't personally have navigation in the office setting, so I really use it exclusively in the operating room. But I know that it is available. We can use it in all these different types of settings and has really, I think, helped us with a greater amount of confidence and also efficiency and time saving for our operations.
Yeah, I think that's a great point. I do use this in the office. So for pretty much any case that I'm doing a frontal, a sphenoid, any ethmoid work, revision polyps, anything like that, I'm going to use image guidance. The other nice thing that I would say is that I think it makes me a little bit faster. So even again, some of these frontals, like the recurrent acute patient, I mean, she was maxillary only, but let's say she also had frontal disease or something. She's never had sinus surgery before. Really, she probably doesn't need image guidance. But in my hands, it's going to be a faster case. I think I'm going to create less trauma. Again, she's awake, it's in the office, she's comfortable, but the smoother I can do the case, the better experience it's going to be for her. And, again, less tissue trauma, I think is always a good thing. So yes, I use it, and I use it in the operating room. Again, unless I'm doing a maxillary antrostomy. And even then, sometimes I like to have it. The other thing that you mentioned, so you can pre-mark your pathways, you can, mark targets, right? Like I want to get for the frontal, for example, if you wanted to make sure that you got that residual auger, you could mark it so that you knew that you were getting it during your case. But you can also kind of put anti-targets, right? Like I don't want to go near the lamina and I don't want to go near the skull base, and I want to be notified when I'm getting close. So I like those features in both sites of service. So we can go ahead and move on to the next slide.
So we have one more poll question, and this is a little bit different from the other questions. We're going to show one more case, and this is the poll question is pretty straightforward based on the CT scan. Would you use navigation? Yes, no, or maybe, I guess. So we can go to the next slide. Yeah, so here's a 50-something-year-old patient with a history of chronic sinusitis with polyps and has had a prior sinus surgery and now presents, again, same medical management, done the budesonide rinses, the course of oral steroids, the antibiotics. In this case, we see a CAT scan that, I think we've all probably seen at some point just pan-sinusitis. Everything looks opacified, right? Everything looks bad. And we're like, yeah, that's probably going to be a clear navigation case. But in this case, kind of what are the sort of things about whether or not we might or may not use navigation? Personally, I like to look closely at the level of the skull base relative to the rest of the sinuses. Is the skull base low? In this case, it's a little bit lower. You could potentially see that it's not as high. I don't necessarily get in there and start measuring Keros types and this and that, but I just think it's nice to get a sense of how low that skull base is going to be. And also the degree of osteotic bone or how hyperdense that bone looks. And I think you can see here in the CAT scan that there's a fair amount of like that thicker bone that appears to be closer to the skull base. You can, closer to the lamina, maybe a little bit on the left side with the lamina looking a little bit more medially displaced, but certainly the bone looks like it's all intact. The frontal might be a little bit more narrowed. So we can go ahead and bring up the poll question. So based on the CT scans, again, would you use navigation? Yes, no, or maybe?
It's funny because I think I'll be interested to see these results. But as soon as you put the slide up, I'm like, yeah, of course, right? Like I'm in this part, at this point in my career, I guess I can't imagine not having navigation for a case like this. Now, again, when I was training, I'm sure when you were training, we didn't use navigation in every case. But I could see it being incredibly helpful here. And I know I jumped the poll gun, but.
Yeah, so pretty overwhelming. It looks like over 90% of people would use navigation, and then some people are, yeah, maybe not really sure. And sometimes it also just comes down to your setup, right? Is navigation going to be pretty easy to set up for most of your cases, or is it you're at a different hospital where maybe you have a nav that you haven't used in a while, or it might be not necessarily part of the workflow and the efficiency. And but yeah, I mean, in this case, I agree with you, Dr. Perkins. I think navigation is very helpful, especially because of the level of that skull base, and especially the location of some of those harder partitions. Just being close to the lamina and the skull base, and knowing that the patient had a prior operation, you know that when you go in there, there's going to probably be some scar that you're going to have to take down. So I do think navigation is very helpful in a case like this.
Yeah, I agree.
Next slide.
Okay, I think last topic is packing, when to pack. So I pack for, not every case. if I did a lot of ethmoid work, if there was a lot of revision polyp work, my preferred packing is Hemopore, the sort of bottom purple packing. I like it because I like the chitosan component, but it also has a little bit of, it's not rigid at all, but it fluffs up. So it will, I think, help keep the middle turbinate medialized if I put it into the ethmoid cavity. And then I'll use Zerogel on the top again, because I like the chitosan component to it. What about you, Dr. Chhabra? When do you pack? What do you like to use?
Yeah, so in my practice, I do prefer the Hemopore. I definitely feel like it's kind of helped me with a lot of my patients in terms of healing. I really enjoy the synergistic effect between the stenting, the hemostasis, the anti-inflammatory effect. It's not only for the patients that I worry about. They might have a coagulopathy, or they might have, take blood thinners, but I do just think it works really well, especially in the postoperative setting. I think that, when I was trained, there was a lot of literature or data, or even debate. I still think there is, to an extent, on what do you do with the middle turbinates? How often do you pack? Do you resect? Do you not resect? Do you bulgarize? Do you put sutures in? Do you put large mirror cells in? So I think that there's still some of that debate that's out there. And I think ultimately it kind of comes down to, what you've seen evolve sort of in your practice for healing. But for me, especially, I think what I really find helpful for these patients is for the postoperative debridement. The Hemopore really makes a nice open cavity. And so those patients, when we kind of suction it out, it suctions out easily. If they're being compliant with their rinses, then it really kind of makes it a much more pleasurable experience for them. I shouldn't say that. It's not really ever pleasurable, but
tolerable, comfortable.
More tolerable. Yeah, maybe a pleasurable experience for me, because I enjoy watching how open the cavities look afterwards, and more tolerable for them. But also subjectively, they walk away feeling more open. So I do think, at least in my practice, I do find that to be a very, very helpful adjunct for healing and for kind of optimizing outcomes.
Yeah, definitely. All right, next slide. I think that is, yes.
Got it. Great points, Dr. Chhabra and Dr. Perkins. So now we're going to take a glimpse at our references and our disclaimers, and I'll ask the audience, please submit your questions via the Q&A if you haven't already. Okay, let's get started. So our first question is, how did you evaluate XprESS technology to make sure it fit your practice needs? Let's start with Dr. Perkins here.
The balloon, like I said, I trained with a wire device, right? I trained with a Clarent. So that's what I used. And I was nervous to start to make this switch. So I tried a case on a head model actually first. And then I liked it, and I tried a case in the operating room, and then I really liked it. Again, for the reasons I mentioned, I liked the tactile feedback. I liked how small it was. I liked that it was reminiscent of traditional sinus instruments that I was used to using. I also liked the fact that one balloon I could use in all the sinuses. I think that there's sometimes, we open 20 different things to do a case, and it seems like a lot of waste. So I love when things can be efficient, both with regards to time and also a little bit more sustainable from the standpoint of like utilization of things. Dr. Chhabra, what about you?
Yeah, I think, for me, I think it was an evolution from the operating room to the office. And it was really, getting comfortable with the instrumentation that I was already used to, and realizing that, people have done this for many years in different forms, and seeing kind of what could be done out there, and seeing sort of how, the balloon works, and being comfortable with the anatomy, then taking that and just, sort of just trying it. Right. And just kind of getting my feet wet a bit, and making sure that the anesthetic technique worked well. But specifically, with the XprESS, I really just felt like it was very similar to the instrumentation that I was already using for frontal work. And that was where I started. I started by using it for the frontal sinuses only in the office. And then I started to adjust it to using it for all sinuses. And I think ultimately what really kind of helped me sort of understand the efficacy of it was just seeing the proof, and those patients that I was taking to the operating room for those limited epimodectomies, for the maxillary antrostomies, now I was offering them a balloon only in the office. The recovery was faster and they were doing just fine. Because, to Dr. Perkins' point, especially if the patients haven't had surgery, you can always go back and do more, right? So I think that has really been kind of a step in my practice that's helped me kind of evaluate patients for the XprESS technology specifically.
Great. Okay. Next question I have here is, when treating a patient, how do you determine the extent of surgical intervention? Might be multiple rounds of medical management or symptom considerations, they ask. Let's take this to Dr. Chhabra.
Yeah, that's a tough question. I mean, I think it always evolves, right? Again, I know I mentioned it, but when I first came out of training, especially, having done a fellowship in rhinology, we're sort of taught every cell, every single time, all the way up, right? And I think that sort of over time really is dictated by the degree of the patient's symptoms, but also the degree of disease. If the CAT scans, like I mentioned, if they're mild and they're recurrent acute, and I know they don't have severe osteitic bone or bad polyps, then I think that the degree of surgical intervention can be targeted to their symptoms and to what we're finding on the CAT scans. Similarly, I mean, there's also data out there that we know that sometimes the radiographic findings don't always correlate well with the symptoms. So even though the CT scan may look pretty clean, like we mentioned, or we saw a case that it wasn't that bad, that patient, I think, will benefit from, an office or balloon dilation. And like I said, you can always do more later. So it's an ongoing thing that I think that, I personally struggle with. I'm sure that we all have sort of our challenges. How about you, Dr. Perkins?
So same, I think that it's a combination of the discussion with the patient about their symptoms, because I think we also sometimes have these patients who have kind of significant CT findings or even endoscopic findings, and they are fine. They are completely they're not bothered in the least. They're using their nasal spray and they don't mind at all. And then you have patients like that first case where, that patient is constantly in, she's very symptomatic. And her CAT scan was kind of not that exciting. So I think that it's a combination of, a discussion with the patient, and also just offering them options. I mean, I'm big about having the discussion of, here are options, here's what we can expect with all of these different options. If we do the more conservative procedure and it's not successful, we can always go on and do a more thorough or more traditional procedure. We can always go to the operating room in the future if we need to. And then similarly, I've had patients with more significant disease who've refused to go back to the OR, but have allowed me to do some minor conservative things in the office to reduce some polyp burden or open, a sinus or something, just because they didn't really want a full sinus surgery. So I think it's a combination of, their symptoms, the CAT scan findings, the endoscopy findings, and then also that discussion with kind of what the expectations are and what both of us would like to do.
Awesome. Okay, up next we have, can you describe how you use the balloon as a tool in greater detail, specifically to find the frontal drainage pathway? Let's give this to Dr. Chhabra.
Sure. So I think that one of the advantages of the balloon, especially the XprESS device, is how it's designed and how that tip is the natural contour fits into most frontals, right? First of all, I think that one of the bigger advantages is also the length of that dilation is, I'm not just trying to target the internal ostium, but sometimes, you want to target the outflow. And honestly, that can be enough for a lot of patients that have recurrent acute or don't have severe frontal sinusitis. So the way I use it in my hand is I kind of use a few different techniques. One, I tend to follow the natural trajectory of where the frontal should be. I try to stay favoring kind of medially, kind of go, sort of posterior to that auger region, medial to sort of that bulla region. And I try to use the probe as, or the distal seeker, so to speak, as a probe. And I don't push with too much force, but eventually I'm able to try to find sort of a natural point where there's a little bit of a give that I can feel. Then I can advance the lighted seeker, the lighted fiber, the light fiber. And then once I have the light fiber advanced, we're able to see good transillumination. Now, that's a point where I think if the frontal is more complex, when I'm doing this in the office without navigation, I'm kind of trusting sort of, what I'm seeing and what I'm feeling. But if you have navigation, I do think it might be helpful if you're dealing with more complex cells, an auger cell, a super auger cell, some sort of frontal cell, that can really help you differentiate. Are you truly in the right space, or are you in one of the ethmoid cells? But then assuming that is in the right space, then I use what's called excursion, just by sort of rotating my hand a little bit to feel that there's some give, that I'm not in a very, very tight or narrow space, and I'm able to have a certain amount of movement with my wrist, and then I go ahead and dilate. So it's sort of those several confirmations, sort of the location that we're able to see, but the transillumination, the lighted fiber path assist, and the feel and the excursion, I think, are all what I use to help find the frontal. How about you, Dr. Perkins?
Yeah, same. The other thing that I would add to that, I think you hit all of the points, is that sometimes I will do serial dilations. So, if I'm in that middle meatus and I'm where I think I need to be, but it's really tight and I'm not quite feeling the space, I'll do a pre-dilation. So I'll dilate to create a little bit of space, and then I'll kind of palpate more. And if it's a really tortuous path, then sometimes it will be a few pre-dilations before you actually are up into the sinus. But I think that's a technique that's been really helpful, that kind of anterograde serial dilation, as far as creating a little bit more space to find the natural drainage pathway.
Yeah, that's a great point. And the last thing I would add too is that over time, sometimes with the serial dilations, I find that just adding a little bit more numbing, whatever your preferred technique is, I use a compounded tetracaine gel. A little bit more numbing just in that area can sometimes help patients if it's sensitive, especially around that middle turbinate region. And you can apply that with even a curved an olive tip or something like that. I found that to be helpful for some of those really narrowed recesses.
Okay, next question. How often do you debride post-operatively, Dr. Perkins?
So for a balloon procedure, I have them start irrigations post-op day 1. I ask them to irrigate at least twice a day. And I don't see them for 3 weeks because they really don't need much debridement. If it's a more traditional sinus surgery, then usually I'm seeing them at about 10-ish days, sometimes a little longer than that. But I'm not a super aggressive debrider. I agree with Dr. Chhabra. I like to use hemopore. I think that as long as the patients are compliant in their irrigating, usually it's not really, there's not a significant amount of crust. You can suction it out. They tolerate it pretty well. So yeah, that's my regimen. Dr. Chhabra?
Yeah, so if it's a balloon, only honestly, I'm not really doing much debridement. I'll usually see them back at about 3 to 4 weeks later. But if it's a traditional FESS or a hybrid, then it's usually about 10 to 12 days. That's kind of my sweet spot. I think anything sooner than 7 or 10 days, it gets a little bit swollen. And then after that, usually a month, and thereafter, every few months or as needed based on the disease.
Okay, a couple more. We're getting lots of questions here. Do you do anything in particular to prevent post-operative infections, Dr. Chhabra?
So I do prophylactic antibiotics. It depends on the degree of, I guess I should say, the type of disease they have. If it's CRS with polyps, I do prefer doxycycline. If not, I may just give them a short course of cephalexin, just prophylactically, anywhere from 5 to 7 days. I do that for my office cases and for my OR cases. That's sort of my preferred method. How about you, Dr. Perkins?
I don't do routine antibiotic prophylaxis. If I have somebody like you were mentioning who had more significant disease and I'm putting a lot of packing in, then I may put them on antibiotic, but most of the time I'm not using antibiotic.
Next up, an attendee is asking, why do the same anesthesial protocol in the OR as you do in the office?
So I'll comment on that just because I think I was the one who maybe elicited this question. So I don't do the same protocol. So I do a combination of oral anxiolytics in the office. So I do triazolam, tramadol, and promethazine pills. And then I do local anesthesia. So I do that in the office. In the OR, I'm not using the anxiolytics. You know, the anesthesiologist can give whatever they give for anxiolysis, but also then they're under general anesthesia. The one thing that I do use in the operating room that was brought from the office is I use the long reinforced anesthesia needle. So this was something that I was a little skeptical about the first time I saw. It's like a 3.5-inch needle. It's 21 gauge. The 3 and almost the entirety of it is 21 gauge, but then the tip is curved and it has a 27 gauge with a little bevel and a little stopper too, where it transitions to the 21 gauge. So it's a Stryker injection needle, but I do sphenopalatine injections in the operating room now as well. And that's something that I do in the office pretty routinely. But I think it does reduce bleeding a little bit for me. So that's why I use that in the OR. Dr. Chhabra, do you do any, I don't know, do you do those injections or do you do a similar anesthetic protocol or totally different?
Yeah, I use a similar, in the OR, the biggest difference I'm using usually topical 4% cocaine on pledgets, which I don't use in the office.
Sure.
So, the RAN needle I use in both circumstances, OR or office. And similar in the office, I use a similar I use oral anxiolytic. I have been using narcotics, but actually in the last, I've been getting away from that and just going to extra strength Tylenol with the anxiolytic. And I do the SPA injections in the office, but in the OR, I'm not doing as much SPA injections. I'm mostly just hitting the axle, the middle turbinate, and some of the post-ethmoid regions and things like that. But I'm less conscientious about that in the OR because I'm using the cocaine as well.
Right.
Okay, another question. Do you trim the head of the middle turbinate routinely? Start with you, Dr. Perkins.
I do not. I don't know if there needs more elaboration. I mean, I try to be pretty conservative. Like I said, that middle turbinate forcep, even if somebody doesn't have a concha, it's a really nice way to add a few millimeters more space in the middle meatus and just kind of smush the middle turbinate a little bit. So I like using that, but I don't routinely trim it. Dr. Chhabra?
I do not either. I agree.
Okay, up next, are balloons or navigation part of your curriculum for teaching residents? Dr. Chhabra.
Yeah, the short answer is yes. It is actually, and I think that that's something that's also evolved over time. I think that it's actually important. It's an important part of the armamentarium of what we can equip, trainees with, because I think that whether or not they choose to use these in practice, or when you go out in practice, or you're already in practice, I think at least having that exposure early on does help if you want to adapt this technology later, because I really wasn't trained on it in training, fellowship, or residency. But I do think that the exposure early on helps. I think that the software especially is great for teaching and showing, building blocks and, the newer IFAC classifications and how to grade some of these frontal cells. So I definitely find that to be a big advantage as well.
Yeah, and I do the same. I just worked with a new to me resident. So this was the first time we had worked together last week. And we had a case in the operating room that was a frontal sphenoid maxillary balloon with some other stuff. And she had never used the Stryker balloon, and she'd never used Scopis. And she was able to, like I did one side, she did one side, and successfully use the device, which I think I can't say she liked it because, obviously she's working with me, so she has to be like, yeah, it was great. But I was pleased that she was able to successfully do the cases, and, she picked it up really easily. But I think it's also important from an exposure standpoint, as Dr. Chhabra mentioned. It's just a tool. So why would you not want your residents to be aware of all of the tools that are available to them? And I think the more image guidance they can see, like the more different types of image guidance, if they haven't had exposure to Scopis, It's a really nice option. So I like to be able to expose people to it.
Excellent. Well, that was it for our questions. I'd like to thank Dr. Chhabra and Dr. Perkins for your insight and expertise and an overall great discussion. Also, thank you to our audience for your participation. Be sure to visit the Stryker ENT website or reach out to your Stryker ENT representative to stay in the loop of medical education and training opportunities. Thanks everyone for tuning in, and have a great evening.